Okay, well, welcome everyone. Welcome to day 2 of the 2023 Interior Health Research Week. I hope you all had the chance to join us yesterday as Elder Bonnie Coble started the week off in a good way. And I hope you had the opportunity to also listen and learn from the incredible panel of Indigenous scholars that shared with us. So my name is Tracy DeLue, and I will be your facilitator today as we discuss rural and remote research in interior health. It is important to acknowledge that I'm calling today as an uninvited guest on the unceded, traditional, and ancestral lands of the Syilx Okanagan people, closest to Penticton Indian Band in what is commonly referred to as Penticton, which loosely translates to a place to stay forever, even though it's pouring rain today. So I welcome all of you to also share where you're calling from in the chat. So who am I? Well, I am a mother of 2, and I would best describe myself as curious and tenacious. I'm also a project and research facilitator with the Rural Coordination Centre of BC and a rural research facilitator with Interior Health. And I'm honored to be here today. And I'm really happy to officially welcome you to IH Research Week's 2023 Day 2, and thank you so much for joining us. So IH Research Week is hosted in partnership with the IH Research Department, BC Support Interior Centre, and the British Columbia Network Environment for Indigenous Health Research, or BC NEAR, as well as the Rural Coordination Centre of BC, or RCCBC. And this year, we have planned 4 days of remarkable dialogues and presentations that aspire to both improve the health and well-being of communities, both close to home and beyond. And these 4 days consist of 3 consecutive days, this October 10th, 11th, 12th, followed by an additional day on October 18th. And we hope you're able to join us for any and all of these 4 days and all the wonderful sessions that are being shared with us. So I just have a couple housekeeping items of note. So the Zoom view, this is a meeting format. And for your best experience for these sessions, we recommend that you select the view in your top right-hand corner and update it to speaker mode, so it's always on the person that's talking. Second of all, please mute. If you're not presenting, please make sure that you're on mute, or you will be presenting. Third, closed captioning is available. At the bottom of your screen, if you hover over your Zoom options, closed captioning, depending on your version, should be there, and you can just click it to activate it. Questions. So every session will have 10 minutes for Q&A after the presentation. And so please type any questions or comments for the speakers in the chat box, and we will share those during the Q&A period. And lastly, for the speakers, presenters will be 20 minutes long, followed, as I mentioned, by 10 minutes for Q&A. Speakers will be notified through the chat by our wonderful Kim Peak when they have 5 minutes left in their presentation time, just as a kind reminder. And on that note, I am honored to introduce you to our first presenter today, Dr. Ilona Hale, Clinical Assistant Professor at the UBC Department of Family Practice and Director of the Rural Scholars Program. And Dr. Hale will be presenting on the environmental impacts of healthcare and research. Over to you.
Thanks, Tracy. Just going to share my screen here. Yeah. Okay, can everyone see that?
Yes, we can.
Yes, we can.
Great. Okay. Well, thanks for inviting me to speak today. I just want to talk a little bit about something I've been working on a lot lately, is the environmental sustainability in healthcare in general. And today, because it's Research Week, I'm going to talk about how that applies to the research world. I'm presenting today from the traditional territory of the Ktunaxa people near what is now known as Kimberley. I have no conflicts of interest to disclose. And really, I think none of this is new to any of us, especially you living in Kelowna. Year after year, we're setting temperature records. This year, again, the hottest on record ever. Our global average temperature right now is 1.1 degrees above the pre-industrial levels. And climate experts typically agree that it's important to limit the warming of the planet to about 1.5 degrees. Unfortunately, we're already on target to hit about 2.8 degrees of warming by the end of this century, which would lead to increasingly complex and difficult to manage climate change risks with cascading, long-term, and potentially irreversible impacts. So that's a little bit scary. And again, none of this is new to people of BC. We are experiencing the effects of climate change already now. The interesting thing when I look around is that aside from, when you're being evacuated or when there's a forest fire on your doorstep, we're more or less continuing on in general society and also in the healthcare system with business as usual. And part of this is because our leaders are not necessarily, certainly in Canada, acting as if this is a crisis that needs to be dealt with. Canada is the worst of all the countries when it comes to our progress on making an impact on climate change. And as we know, climate change is having direct impacts on our health with things we see every day. It's also anticipated that these changes are going to get worse. So that's a lot of bad news. The good news is that we are becoming more aware that our health as humans is entirely dependent on a healthy ecosystem, a healthy planet. And we need to be wise stewards of the resources that the planet provides us: clean air, clean water, and a stable climate. And that is within our grasp. The healthcare system itself, ironically, since our mandate is to promote and protect health, but the healthcare system also contributes to climate change. On average, globally, most countries contribute about 5% of their total greenhouse gas budget comes from the healthcare system, and Canada is similar to those. So this is just a quiet reflection question. What part of our Canadian healthcare system do you think contributes most to climate change? And I'll just let you look and think. I didn't set up a Slido or anything here. So traditionally, we've always thought of environmental action in healthcare to mean we're making our buildings more efficient, we're turning off the lights, we're reducing paper waste. But as it turns out, most of the impact of the healthcare system comes from outside the walls of our facilities. It comes from, as you see here, things like medications and hospitals. And the majority of the impact from hospitals is, again, not the heating, cooling, and the electricity that's used, but it's the stuff we're using in the hospital. So it all comes from upstream in the supply chain. About 80% of it comes from upstream. And you can see here that as a clinician, for me, this was a really eye-opening thing to learn about, because I realized that I don't have to be an operations specialist and retrofit a hospital to make a difference. I can make a difference in my day-to-day work by just using the resources we have, lab tests and x-rays and medications and procedures more efficiently. To give an example of what I mean, when we think about ordering a lab test, for example, we often congratulate ourselves because we're using an electronic rather than a paper requisition, and we've saved a piece of paper, which is great. But when the patient goes to the lab, they use all kinds of needles, syringes, Band-Aids, gauze, armband, a bag, and then the sample needs to be processed, and it needs to be often shipped, especially if you live in rural BC. And for each one of those little pieces of material, the natural resources need to be extracted, and then they need to be manufactured and shipped and processed, used, and then ultimately disposed of. So this is what I mean when I talk about that upstream supply chain. It's not just about turning off the lights. And so this is where most of the energy that's used in the healthcare system comes from. Fortunately, we are seeing some leadership on climate change. Interior Health has been very progressive here. The federal government and the provincial governments have signed on to programs saying that, yep, we do need to pay attention to this whole issue of climate and the healthcare system. Interior Health just launched their roadmap last week. And one of the parts of it did refer to quality improvement, not research specifically, but they're definitely thinking about it. We're also recognizing that this environmental sustainability has to be a key dimension of quality in order to provide safe, and equitable care. We need to really start thinking about the concept of do no harm on a broader, not just an individual, but on a population and a planetary level. And again, not just today, but into the future. So when we care for the planet, we really are caring for people. And as we've been working on this, we've learned that, initially, I think a lot of people were nervous. So, well, we don't want to be prioritizing the environment over patient care. And what we've seen is that when we do prioritize environmentally more sustainable approaches to doing things, it turns out that in almost every case, it is actually also better for people. It's often better for providers. It reduces wait lists and burdens on providers. It's often cost saving. And it makes us more resilient, and it leads to healthier populations. So this idea is a win-win-win. There are 4 basic principles of how to provide environmentally sustainable healthcare, and I want to really apply these to research today. The 4 principles are reducing unnecessary care, empowering patients to be more active in their own care, shifting towards health promotion, and then the one we usually think about is switching out to more environmental alternatives. So when it comes to research, we can think about these environmental alternatives, and a lot of them, if you do put any energy into thinking about it, you realize, oh yeah, if we travel less, do more virtual rather than, in-person interviews or whatever it is, we can do that. You can also, in your research facility, reduce energy, pay more attention to materials, consider reusable alternatives. And then some groups are advocating that research teams should be measuring their environmental impact. Research can have a substantial environmental footprint. There haven't been many studies done on this, but one that was done back in 2007 showed that a single study that was done in the UK, it was large, 10,000 patients in many countries, did account for about the same annual carbon use as 160 people in the UK, or that's also equivalent to 525 transatlantic flights. And that's just one study. So when you think that in Canada, CIHR alone funds $1.3 billion worth of research, that's quite a lot. And at that time, they weren't even considering the carbon footprint of the medications they were using. They were just focusing on travel and the energy used in their facilities. Another more recent study said that of the 350,000 clinical trials that are registered on clinicaltrials.gov, the emissions from those trials would be about the same as 1/3 of the annual emissions from an entire country of Bangladesh. So it's not insignificant. We do need to be thinking about it. A really easy place to start is just doing more of this. I'm not here in Kelowna, I'm presenting virtually, and that's awesome because there's a really big, so when you're disseminating your research or when you're going to learn about others' research, obviously doing it virtually has a huge benefit, especially if you're avoiding a flight. And the longer the flight, obviously the bigger the impact. Researchers can also help advance this whole agenda by choosing to research things like this and provide the world with more information about how we can do better by choosing different alternatives. So this is a great example of, a policymaker is going to have trouble arguing that, and it's not on here, but it's also cheaper to use the reusable. So, producing data like this helps us move forward on the reusable product field. The second principle is just about avoiding waste, similar to reducing unnecessary care. There is a lot of waste in research, and I don't mean the physical waste, I mean the unnecessary research. It's estimated that up to 80% of the research that we do does not actually end up ultimately leading to patient benefit. This doesn't mean studies that end up being negative, that they don't, find what was expected. I'll talk more about how we can reduce this waste. But even 30 years ago, they were saying we need less research and research done for the right reasons. So the NIHR in the UK have come up with guidelines on reducing the carbon footprint in research. And their key recommendations are basically do good research, like do really high quality research, which I'm sure all of you are doing. And that starts with asking good questions based on what do the end users, whether they're policymakers, providers, or patients, what matters to them, what's actually going to move them to change something and make things better. And then do your homework, make sure you're not duplicating something that's already been done or doing something without knowing, fully what's gone on before. The other things are just about don't do excessive monitoring or data collection, and make sure you get the information out there once you're done. You can't have this stuff sitting on the shelf, or really that your efforts have been wasted. One thing that wasn't on there, but I think is really important is we need to, if we're going to get out of a lot of the tricky predicaments we're in right now, is we need to work more across disciplines and get out of our silos and start talking to people who know things that we don't know. Because the wicked problems we're facing right now are not going to be solved using the same approaches that we've used all along. The Lancet Reward campaign was also developed again to reduce waste, and they have very similar recommendations. Sadly, despite all this, even in some of the really highest quality journals, when they actually looked at just one of these things, are people making full use of existing evidence? Sadly, the answer was in most cases no. They would fail to mention other research that was done. They would claim that they're the first, but actually they're not. And they wouldn't necessarily use or cite the previous, systematic reviews that had been done. So that's a little disappointing. We can do better. The next principle and the start of really thinking about what to study is, again, as was mentioned in those NIHR guidelines, patient-reported outcome measures, asking patients, empowering them to find out really what matters in the big scheme of things. When they did a study looking at different types of studies, on the far right, you see these are commercial trials, and they obviously focused on drugs, vaccines, and biologicals, things that would make them money. Yet when they asked patients what kind of studies should be done, they looked more at things like education, training, service delivery, and interventions like psychological, physical, or diet. And then non-commercial trials were somewhere in the middle. And it turns out that the patients are right, because what makes us sick or what makes us healthy, very little of it has to do with our healthcare system. Certainly even less has to do with the occasional silver bullet that comes out of this, bench research. And most of it has to do with other things, social and environmental determinants of health. And that leads to the last principle, which is shifting our focus from the sort of high-end tertiary care, resource-heavy, energy-intensive type of care that we provide, when patients are very, 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 very sick. Our healthcare system's very good at doing that. We're less good at keeping people healthy and keeping them out of the system in the first place. However, when they look at this, health promotion and prevention is more effective, less expensive, and more sustainable. This framework that was developed to describe how to achieve a sustainable healthcare system starts with reducing demand for healthcare. And that means addressing those social determinants of health, working towards better health promotion, disease prevention like vaccinations, and then better management of chronic diseases to keep people from developing complications. Not only is our system not environmentally sustainable, it's also not financially sustainable, and these two things go hand in hand. And so we need to be thinking about them from both points of view. Developing and researching ever more expensive $30,000 a month biological medications is not sustainable. When we think about applied versus bench research, applied research has consistently been shown to have larger health, social, and economic effects than preclinical research. And very few of them, it's like winning the lottery to actually have bench research lead to something that is clinically meaningful. And it takes a long, long time. But again, the time this study was done, the majority of funding was still going to bench research or basic research. Now, it doesn't mean that basic research is bad, and I'm not here to judge, but just if we are having to choose, which we might have to do with limited resources, and you know, the general principles are that applied research is more helpful. And then there's this concept of uneconomic growth, and in already wealthy countries like Canada, many of the things that were sort of unarguably good for us, like healthcare and you know, food and other things like that, we've sort of hit a place where we've gone a little bit too far in a lot of ways, where the harms generated by our consumption start to have negative impacts that outweigh the consumption's overall benefit. And in many ways, our healthcare system is at this point. This is just a schematic that sort of outlines the, you know, the problems of the overconsumption and misconsumption happening in our society, how these things lead to health harms that, if we were effective in managing and preventing some of this misconsumption, these health problems wouldn't develop. But when they do, then it leads patients into the healthcare system where, again, the excess overconsumptive nature of the healthcare system can lead to more problems. And it leads to this vicious cycle of, you know, our healthcare system no longer making people healthier. There's a great article by a man named Kaveh Shojania. He wrote this for the CMAJ, and he said, what problems in healthcare should we be targeting as the world burns around us? And it was really meaningful for me. And he gave this out. There's just one example that I love, you know, statins, cholesterol medicines, $20 billion per year, postpone death on average by 11 to 17 days. And with that same money, we could also choose to house at least 1 million American families. So it's just something we need to think about. Again, statins aren't bad. They help a lot of people. But we might be facing these problems, these questions. Other types of research that could be done would be looking at something like plant-based diets and recognizing it's one of the most important and both environmental and health changes we can make. And maybe doing research related to that, like front of package warnings on red meat, for example, might be a more effective way to be moving our research agenda. So really, I think as a society, we can only implement research evidence that once the evidence is available, and we can only get answers to the world's important questions if someone asks the questions. And so if the research agenda is guided only by people who profit from the results, the most important questions that can lead us to a more sustainable society will never be measured. As researchers, you have a really important role to be the ones to pose these critically important questions and lead us to a better, more sustainable and more equitable future. I don't know how I'm doing for time.
You're doing great for time. You have 2 minutes to Q&A, so you have time to spare.
Oh, good. Okay. I was probably talking really fast. I was worried that's going to go over time. Yeah, so this is basically the summary. We got to think about how we do research, what we do research on, and yeah, think about the end goal. I don't know. That's it. Maybe questions. Good time for questions.
Perfect. Thank you so much, Dr. Hale, for your presentation. I took a page of notes myself, so it's fascinating. Oh, and we actually have a question right away, so maybe I'll start by reading that out. So thank you, Ilona, for sharing this timely research with meaningful reflections for all of us to seriously think on. My question is, for a researcher wanting to start building pathways within their work for sustainability and change, where would you suggest they start?
I would suggest that you start by reading those the guidelines from the NIHR, and I've actually I put the full sort of blown out guidelines on the end of the presentation, so that'd be a great place to start. And I think the easiest place to start, because most of us have our research interests and research programs, and we're not just ready to switch tracks to do something entirely different. But is to make changes within the the work that you're already doing. And then, like I said, I'm sure we're already all doing this, but a lot of attention to that high quality research where you, you know, this has happened to me. By the time you're finished collecting your data, sometimes, just the work to disseminate it's a lot of work. And sometimes we just get excited about our next research project. And so, but remembering how important it is that we get that out, work just as hard on disseminating the information as you did on collecting it. That for my own personal experience, that would be another place to work.
Perfect, thank you. And there's another question in the chat from Barb. So Barb has said, thank you for the great summary. How do we work across disciplines and what do we do first?
Yeah, so I think working across disciplines, when I think of that, I think a lot about the health promotion side, especially because, you know, in my mind, we tend to get focused on the medical solutions to medical problems, but so often the solutions to medical problems lie within the education sector or the social, you know, social support networks sector. So I think guaranteed annual income and free daycare and that sort of thing would probably have more of an impact on a lot of chronic diseases, preventing adverse childhood experiences. So that's in the work that I've done, that's sort of been my conclusion, is that, you know, if we just keep doing what we've always done, we're, you know, within our own silo, we're not going to come up with those more creative answers. And I think, you know, engineers working with medical professionals, again, they just see the world in a different way. Mm-hmm. Even physicians working with nurses and midwives, you know, we all have our training, and when you put all those brains together, depending on what the issue is, new ideas come through. That's been my experience. What was the other part of the question? Where do we start?
What do we do first? Yes, a lot of people wanting to know what we need to do.
Yeah. So again, I go to those guidelines, and there's some good articles. I've got a big long list of references at the end of the presentation too, and you could read any of those. But some of the best ones, if you're going to just look for the best ones, the most recent ones on the bottom of the list are, I would say, some of the best. So that's what I would do, and just keep thinking about it. How can I apply any of these to the research I'm already doing? Because everybody's doing different research, so the answer is going to be different depending on what you're doing.
Thank you. And I love how you said during your presentation that prioritizing environment will lead to healthier populations, which really is speaking to what you're saying now, which is if we bring new ideas and bring different views together, like the outcomes will be different and probably better overall. So I appreciate that expansion. I have a question about, you had mentioned that learning that the upstream in supply chain was kind of the biggest surprise for you, or a surprise for you in during your research, that 80% of the impact kind of came from there. I'd love to hear more on that and why that was surprising, and what you think we can do next in that area, if anything. Yeah.
So again, this was more a surprise for, you know, me, the clinician, because again, I think we tend to think about the, again, environmental action, like Interior Health's environmental department was primarily operations, right? It was like build better, like more energy efficient buildings, and, you know, timers on the lights, switch out to LEDs, you know, it was that kind of stuff. And sometimes it was changing to 100% recycled paper, and those physical things that we see right in front of us are, and the recycling the trash, like those were always our typical sort of environmental go-tos. You know, if we want to be more green, we do all this stuff. Whereas very few people think about, you know, the choosing wisely principle. So being more careful resource stewards about not ordering medications inappropriately, which we do about 30% of the time. The care that we provide is actually unnecessary, which is shocking. And so don't order those extra lab tests. Like that's a big part. And don't order that x-ray if you don't need to. Choosing Wisely has a bunch of really good guidelines about all the stuff we do all the time that we don't have to do. And I think it relates to, I think how we behave as a society as well. We worry about recycling the package that the Amazon product came in, but we don't think as much about, did I really need that radish chopper, you know, like and that sort of thing. So I think it's that mindset for me that was like, oh, you know, just where to put our priorities.
Perfect. Thank you. I'm just going to give a minute to see if there are any other questions in the chat or comments for Dr. Hale. So I do have another one from Kim. So you mentioned patient partners, and I wonder if you might be able to share your experiences with patient engagement in research projects you've been a part of or led.
Yeah, great question. So I haven't done of course, I try to engage patient partners, and I think in general the experience, and for most people who've done this, is just that there's a lot of ahas, and there's sort of you get better research when you ask again, lots of different partners, including patients, to be involved, and you don't waste time doing a survey that, you know, the patient didn't understand, for example. Whereas if you just had a patient help you design the study, it would have been a better, you know, a better questionnaire. So that kind of thing. And for patient identified outcomes, things like, you know, what really matters to a person living with obesity, for example. It may not be what we think. And so it's that kind of thing, but it's very powerful. And I'm glad to see Interior Health is really doing a lot with patient-oriented research. So thank you, Kim.
No, thank you. Perfect. So I have probably another minute. Oh, I do see Jason Curran has his hand up. Jason, you're welcome to come off mute and ask your question.
Yeah, thanks, Dr. Hale. Great presentation. So here's what bugs me, and nothing what you said actually. It's that many of the changes that you're suggesting or that you're kind of alluding to could potentially save the healthcare system a lot of money. And that's what I can't understand, is that some of the areas in which to lower emissions and to decrease the impacts actually save money. And so I can't wrap my head around why it's not happening a lot faster, why changes are not happening a lot faster when they're a lot cheaper. And you gave that example of the disposable gowns versus reusable ones. So I also have another question if there's time. Okay.
So this might sound a little cynical or a little bit like a conspiracy theorist, but to be honest, I think it's because a lot of the things that we're trying to get rid of, we're trying to switch back to a simpler time. And typically that means we're consuming less, we're buying less. And the people who sell things don't like that. And so they are driving, and when it comes to medications and even medical supplies, they drive the agenda. You know, they come to the hospital procurement committee and say, we got this great new disposable thing. And they'll provide information to suggest that it's better, it's safer, you know, you don't want to be using that old stuff. They've convinced us that and the reason they're doing it, obviously, I mean, they are companies and their job is to make lots of money. And so selling one item that lasts for 10 years it's not a good business model for them. And they've managed to convince the people who make these decisions within the healthcare system that they're right and that we must move on from the old-fashioned ways. That's my understanding of why it's taking so long.
Thank you so much. And Jason, if your second mini question is quick, we will have time.
Super quick. Thanks, Tracy. So I'm just wondering, from your point of view as a clinician, you gave the example of the statins versus housing tens of thousands, millions of people. And I'm wondering if that is a decision that you as a clinician are prepared to, I know you're not making the decision, but like on a micro scale, if you're prepared to make those sorts of decisions that make a lot of sense, but they're not necessarily the easiest of decisions.
No, they're really difficult decisions, especially because in the one-on-one relationship with a patient, my duty is to my individual patient. But what I do, and the other part of the, the other principle that comes to play when we're talking about statins, for example, is patients' right to choose and to get good information, and then empowering them with this information to decide. And many patients, if you give them that data and say, well, you can take this pill every day for the next 25 years, and it's on average going to reduce the chance of you dying or extend your life by 10 to 17 days. Many of them will say, oh, well, I don't want it, and you can present it in a number of different ways to show them, like, what's the likelihood that you're going to have a heart attack with and without the drug. And many patients will actually say, oh, well, then I don't want it. Like, if it changes my risk by 1%, they're going to say they don't want it. But it is difficult because there are a lot of guidelines, especially around statins out there, that depending on, I see Denise here, and the internal medicine specialists have different guidelines than the primary care practitioners, and we're often caught in a difficult place when we have to try to provide that information and help patients decide. But I try to give them as much information and then let them decide.
Amazing. Thank you so much, Dr. Hale, and thank you everyone for your questions and comments. I'm sure there's a list of us that are looking forward to looking at that last page of references following these sessions. So thank you so much for your time today.
You're welcome. Thanks for having me.
You bet.
I wish I could.
Well, we'll record this, so we'll send you everyone else's presentations too.
Perfect.
Thank you. See you. And with that, I'm really excited to introduce our next group of presenters. So Dr. Denise Jaworsky, Jen Siemens from the College of the Rockies, and fourth-year nursing students, Ashley Giesbrecht, Nick Eliasson, and Catherine Motion. And they'll be presenting on a snapshot of research collaboration in the East Kootenay region. So I'm just going to give a moment for wonderful tech support to cue all those wonderful presenters up, and the stage is yours when you're ready.
Thanks so much, Tracy. I think I'm starting out for our group, and I think Jen is managing the slides. Hi, everybody. My name is Denise Jaworsky. I identify as a physician of Japanese Canadian ethnicity living on the unceded territories of the Ktunaxa Nation. And I am going to talk to you a little bit about our hopes and plans and what we've done so far in terms of bringing more clinical research to the East Kootenay region. And I am doing so in partnership with Jen from College of the Rockies, who I guess will introduce herself when she starts her slides. Next slide, please. So really, as we try and develop rural research capacity, one of the big things is that no one group can really take this on, and it needs to be a partnership from multiple different organizations. And we've been fortunate so far to have started building partnerships between Interior Health, College of the Rockies, and UBC, and our research capacity building plan has been supported by funding from CIHR, from the Accelerating Clinical Trials Network, and from the Rural Health Services Research Center at UBC. Next slide. And so our research team is really just starting out, and we're hoping to engage more learners from multiple different organizations in the work that we do. I put together this slide because we've been so fortunate, even this year, in having 4 super keen, really awesome medical students who want to do their FLEX project. And so a FLEX project is sort of a research or academic project that students take on throughout their undergraduate medical education. And we have 4 amazing, keen medical students, most of whom grew up in rural communities, including rural communities in the East Kootenays, really want to be a part of our program, which aims at building clinical research. And so you can see all of their lovely pictures, as well as a bit of a statement from each of them in terms of why they want to get involved in rural research. Okay. And so The main thing that we're trying to do is bring clinical research to the East Kootenay region, or sorry, bring more clinical research to the East Kootenay region, recognizing that there already are many projects going on, as you've already heard from Dr. Hale. And one focus area that we have is advancing clinical trials. And clinical trials are really essential for the generation of best clinical practices and understanding and approval of new potential therapies. The Canadian Institutes of Health Research recently created a national clinical trial network with really the goal of increasing Canadian involvement in clinical trials. And as a part of this, there's a real focus on supporting community-based and rural sites to ensure inclusivity. In the past, most clinical trial enrollment has really been through large academic centers, but the goal with the Clinical Trials Network, and the network is called Accelerating Clinical Trials, the goal of this is really to democratize clinical trials and really make it possible for more patients and really anyone to participate regardless of their geography. And really, this is essential to allow equitable access to potential emerging therapies, but also to make sure that the data generated are representative of rural populations. And one of the examples that I like to use around why this is so important is with the early COVID vaccines. And so one of the first COVID vaccines that was approved had to be stored in -80 freezers with very sort of strict storage criteria. And the trials were done really in major urban centers. And I was working up in northern BC when the product came to market. And really what we found is that all of a sudden there's this vaccine that's now available, but we did not have the infrastructure to be able to store vaccines across multiple small rural sites in -80 freezers. And so this was a big oversight in the product development that really didn't account for what the real world and rural experience would be. And so that's my example as to why it's so important that rural sites are included in clinical trials. And so really what we're looking to do is develop Cranbrook, or East Kootenay Regional Hospital, as a clinical research and clinical trial site. And this is going to happen alongside two other interior health sites, which you guys might have heard about already, but Kelowna and Penticton are also working on further developing their existing clinical trial infrastructure. And it's really great to have this partnership amongst multiple IH sites to be able to sort of work together and share resources. And so some of the things that we're planning just at our site in Cranbrook is a research team building workshop. And this has been funded by the Rural Coordination Centre of BC. Oh, no, sorry, actually I got that wrong. Sorry, that's the Rural Health Network of BC. Oh, sorry, go back. Oh. And that I've got a slide about that coming up, but that's going to be on October 20th. So I would actually welcome anybody here that wants to come join us to please come to that meeting. And that's going to be at College of the Rockies. We want to put together a long-term research advisory board to help us to decide what trials are feasible and what trials really meet the needs of our community members. And then also look at our site resources and determine what are feasible trials, because obviously we only want to take on something that we know we will have success with. And so next slide. So here's the information about our research team building day. It will be held at College of the Rockies, and my email address is there. So if you are interested in coming or want more information, send me an email, please. Next slide. And so Jen will talk a little bit more about this, but recently we were in Charlottetown in PEI at an annual Accelerating Clinical Trials meeting. And really this was an opportunity to network with other sites who are engaging in clinical research, and also hear about potential clinical trials that our site may in the future be able to be a part of. And I did get to hear about a couple different projects that seem like they would be feasible within our hospital setting. So that's really exciting. One thing that the Accelerating Clinical Trials Network is actually currently calling for, and I know there was recently a question about patient engagement, but the Accelerating Clinical Trials Network is developing a patient engagement committee, and they're looking for a couple more members to join this committee to help develop best practices for patient engagement within the ACT network, and to sort of explore barriers and gaps to patient engagement, and find ways to promote patient engagement in clinical trials. So if anybody is interested in being on the patient engagement committee, please get in contact with me and I can forward you more information on that as well. And so with that, I'll pass things over to Jen to talk a little bit about some of her highlights from the meeting in PEI, as well as some of the research that's going on at the College of the Rockies. Thanks.
Thank you, Denise. Can everyone hear me okay?
Yes, we can.
Oh, great. So my name is Jen Siemens. I identify as female. She, her are my pronouns. And I am joining you today on the unceded territory of the Ktunaxa people. My ancestry is predominantly Scottish, with a whole bunch of other little additions as well. I attended the consortium as a representative for the College of the Rockies, particularly for the BSN program, where I support our nursing students in the 4th year in participating in various projects throughout all of British Columbia. And so I found a few resources that were useful that I thought I would share as we start to think about what an RCT might look like within Cranbrook, in case anyone's interested or has not already heard of these wonderful tools that have been developed. So one of the tools was the Guidance for Good RCTs. It's developed by the Good Clinical Trials Collaborative, and it's a really easy read for anyone who's interested in creating an RCT. I also pass it on to our research course instructor for our students, just because it's a great resource for learning more about them. Additionally, as Denise noted, there's a lot of research that happens across Canada in non-research intensive hospitals. And so there's a project right now creating a toolkit that will be released later this year to support non-research intensive hospitals like EKRH in developing research in their sites, in addition to the wonderful framework that's been developed out of Ilona that already exists, which is so wonderful to have as a resource going forward. And then another tool that I found interesting, particularly focuses on oncology, but also relates to what Dr. Hale was talking about in regards to reducing emissions and increasing access through an interesting model called the hub and spoke model, where oncology research can access patients in rural and remote locations without leaving them out because of their geographic location. So a few of the projects that we have going on right now as a result of just where we're at as new sort of researchers. We have actually done work with Dr. Hale in the past, which I'll speak to in a moment. But right now we have students working with the Interior Health Critical Care Network, looking at could the use of a clinical laddering tool support new critical care nurses in their transition to practice, thinking about retention of nurses within Interior Health. We have some students who are working with the BC Nursing Policy Secretariat, looking at barriers and facilitators to learning pathways in BSN education at the College of the Rockies. And we have had these learning pathways in place within partnership with Interior Health for a while now, but not within our exact location. We have some students working with the EKRH nurse educator, and they're looking at the uptake of a tool used to support nurses in practice to improve patient care and increase supports for nurses called the CotR tool. And we also have students who are here today who are with the Patient Engagement and Research Network. And right now they're exploring ways to advance patient engagement and research within our local communities. So looking at similar to what the ACT group is looking for on a national level, but considering more so what it will look like here in our local hospital when we have the RCTs going forward. So in the past, some of our past placements with our students has included placement with the Rural Coordination Center of British Columbia, Patient Engagement and Research, BC Patient Safety and Quality Council, the BC Cancer Agency, Nursing and Allied Health Knowledge Translation, Patient Voices Network, and as well as a couple of projects with Dr. Ilona Hale and Steph O'Bara, who's also a colleague at the College of the Rockies. If you're interested in hearing about these wonderful projects, you are welcome to join us via Microsoft Teams or in person. So we'll have our 6th annual UVic at the College of the Rockies Bachelor of Science in Nursing Student Leadership Conference. And that will be on Thursday, November 30th from, depending on your location, from 8 a.m. to 1 p.m. Pacific time. And if you're interested, please send me an email. My email is there. And that's the end of my presentation. And if you'd like, I've asked the students to attend as well if you have any questions for them. Thank you.
Amazing. Well, thank you so much, Jen, and thank you so much, Denise, for your presentation. I think we would all love to hear from the students. I know I would. Perhaps we can open up for questions and see if there are any direct questions for either Dr. Jaworsky or Jen or any of the students. So maybe we'll start there.
I wanted to say that I'm excited that Dr. Hale is joining us on our team building day to consider what this looks like going forward.
Amazing. And actually, that's a great place to start. So I actually had a question about the team building day. So it was mentioned that it's coming up, and I think that was on October 20th, that's the workshop, and that it will be in Cranbrook, I believe. So is there an opportunity to join virtually as well, or will this just be an in-person event this time?
We will have virtual participation options. Some of the activities are going to be a little bit more like small group discussion or kind of roundtable, which is always harder to do virtually, but we will make virtual participation possible.
Perfect. And who's kind of needed to join that to make this successful? Like, who are you really hoping is going to jump on board and get involved at this point? Obviously everyone here, but if you had to put them in categories.
Yeah, so I mean, that's a really great question. Because we're so early into this work, one of the ideas is just trying to find out who out there is interested in research. And so really anybody that has even the slightest little bit of interest in research and health research, we want at the table. Oh, Jason, do you have a comment or a question, Jason? Oh.
I have a question after, sorry.
Oh, okay, sorry. And so we want to have some health providers and health professionals. We want to have educators and people involved in training of learners through the college and UBC. We want IH research members. We want patient partners. We want community members. And really just to get anybody that wants to be a part in guiding the discussion, guiding the plan forward is welcome. And students,
Amazing.
learners, lots of
and
learners.
Students. Yeah, amazing. That sounds like a great opportunity. And I'm happy to help circulate that information after these sessions too. It will be in the recordings, but I'm sure we can include it.
I've shared the info for both the team building day and the conference in the chat.
Perfect.
I also wanted to note that I believe we also have a patient partner from the peer network who's attending today. I recognize him from attending past sessions. It's nice to see you. Thank you, Paul.
Well, welcome, Paul. I did see that you joined as well earlier, actually. So maybe what we'll do, I'm happy to pass to Jason for a question, and then I'd love to hear about the students' experiences, or Paul as well from the patient engagement perspective. But Jason, we'll let you go first, and then I'll pass the mic on.
Sure, I can ask questions for everyone. First of all, Ashley, Catherine, and Nick, you are the students on this project, right? Okay, so I got really excited to see that medical students interested in research, judging from your quick bios, I saw wanting to practice rural. That's very exciting. So I'm just wondering if you could comment just generally on, what makes you interested in rural research? Because I think going back to what Dr. Hale said, applied research is there's a big bang for the buck, especially when it comes to environmental impact. And most research, or most rural research I find, is applied research. It solves a problem that's local or regional. So I'm just wondering generally if you want to just comment on getting involved in research, because I know you're all busy with clinical training as well. So it's not an easy task.
I'm just going to jump in and say these are our nursing students who are paired with the
I'm
peer
sorry.
team. That's okay, but we do have medical students attending. So
Okay. Well,
perhaps they can take up that question.
I'll ask the same question to nursing students because it's equally applied.
To jump in, or do you want? You can go, Ashley, and then I'll follow up.
Okay, sounds good. Yeah, we're like just starting to learn about what peer is. We were placed with them for our clinical placement this semester, which we learn about like research and leadership is mostly our focus of this semester. But in terms of like our interest in rural research, I think personally, I'm just really interested to see what the team building meeting will hold, because me and Catherine and Nick have all been invited to that. So I think I'm just really excited to see where that will go, but I'll let Nick speak now.
Yeah, I agree. It's going to be really good to go to that team building, and then just also to reiterate, being involved with this IH Research Week event provides us as students a unique opportunity to observe the foundational aspects of research and how we can amplify that patient voice in a research setting. So from what we've gathered so far, this area certainly needs more of that research in general, and then also patient involvement. But yeah, it's still very new. Like Ashley stated, we're just getting into it and kind of building that foundation to start growing that action. So yeah, we're just excited to be here and be part of that.
Well, thank you, Nick. Thank you, Ashley. I'm not sure, Catherine, would you like to add anything? No? Well, Paul, I see you on the top of my screen now too. So I'd love to hear about your experience with working with this team and what that's meant to peer and to you.
Well, I'm on the patient engagement and research committee there as part of Interior Health's research department. So it's been around as a committee for about 5 or 6 years. And part of that is, again, we've sort of looked at how do we inform patients that their ideas and lived experience is also valuable to the research community, not just as test subjects, but as expressing, how do you get the information out to people? What does the general population think about research? So it's a multifaceted side of things. Your presentation earlier there on the multi-partner aspects especially in the sort of rural areas, I think is a really good direction, that we're all part of the system and there's challenges all the way through. So as part of the committee, we've started to look at assisting some of the students there at CotR in the nursing program. So we did that last year with a group, and then certainly our new people here that are participating with us. I think what we bring is kind of a broad experience that certainly all the people on the committee have networks with various other committees in health side of things. I'm not a health person, I'm a industrial research sort of person, but again, it means that we bring in a lot of different viewpoints, and the general focus is how do we use the experiences we have combined with other people to move things ahead. And I think as a committee, we try to assist research people to understand, if I have a person like myself, he said, yeah, well, he's all about electronic weird communication stuff and heating programs. What does he know about us? And what we often do is there's expertise that, you're trained in health side of things, which, I have nothing in that. But I have lots of management experience and grant writing capabilities and things like that from an industrial perspective. And so when we're challenged in the healthcare side of things, of where do we get support, looking at the patient side of things is often a way of increasing the support for whether it's a research project or knowledge or even access to try to bring the results of that research out to the public. Your knowledge translation, horrible patient wording, knowledge translation. I wondered what language you're translating it into, but so there's even things like that often we've been involved with reviewing various people's sort of presentations to make it in language that doesn't use things like, well, it's KT, and that it's a blending together of resources that haven't really been looked at of how do we support it. There's financial side of things, that there's other sources of funding besides Interior Health and the ministry and then CIHR that are out there. There's a group, Health Excellence Canada, that is supporting a lot of outreach to rural and remote sort of activities that one should look at. And I think from a student perspective, it means there's things you can do even while you're studying, which can make really big advances in the medical side, because you're immersed in a system and you're kind of coming into it. So there's questions that you ask, which other people say, well, no, we've tried that, it didn't work. But maybe there's time to change, right? It didn't work when we had a telegraph, but an Apple iPhone means that things can work now, right? So, don't be afraid to speak up, and we try to help that. And again, keep it as, can we help the researcher people interact with people, general people with their lived experience? How does it fit into your research? How does it fit into your grant writing? And the same from the patient side of stuff. How are we involved to make our communities better? So that's peer.
Yeah, no, thank you so much, Paul. I've enjoyed working with peer and the times I've had the chance to, and I look forward to more in the future and learning more about the great work that you're doing with Denise and the team in Cranbrook as well. So it sounds awesome. If you're able to, we'd love to share any links or information to peer for those that this may be new to in the chat. So if you do have a link or anything you'd like to add to the chat for people to take a look at, please feel free to. Otherwise, we can always send some information around following the conference as well.
And can Kim just pop in the proper link?
Yeah, I know Kim probably has it too. Yeah, so if someone can drop it there, that's great. If not, we'll make sure folks can access it afterwards. But thank you so much, Paul, for sharing with us today. And actually, that brings me, everything you were speaking about, actually, Paul, really brings today together so far. And with the inclusion of the Flex students, patient engagement, nursing students, different researching staff, it's so wonderful and encouraging to see. And this is kind of just a question for the general panel of folks here right now. But what are you most excited about? What opportunity is most exciting to you? And then I'm going to let other people ask questions in the chat, because I recognize that I've just been chatting along with all y'all, and maybe somebody else has something they want to throw into the ring. So what is the most exciting opportunity you see right now? And then we'll see what other people have to add.
So I can go first.
Go for it, Denise.
I think for me, really, the most exciting thing is actually to kind of show the world what rural communities can do, and yeah, really just be a model of how good research can come out of really small places, and that people need to stop overlooking rural communities as just, it's too small to do anything. So really, that's what's most exciting to me.
Thank you. Jen, did I see your hand up, or were you? Yeah, go for it.
As a registered nurse whose focuses on rural nursing practice, I'm very passionate about improving the health outcomes for rural and remote Canadians, particularly in our region, and interior health cares for almost 900,000 people living in rural remote communities. And so if we can have research born of these communities, then we can potentially improve the care for them as well. And so I'm just very excited about creating an opportunity for patients to engage in that research and for the public to engage in that research.
Thank you, Jen. And Ashley, Nick, Catherine, Paul.
Yeah, a quick comment.
Yeah.
You know, from a patient side of things, when you're sort of looking at, you know, what are capabilities out there to enhance research? You know, I'm over in Nelson, and there's a company here who designs accelerator beam lines, which are used for medical isotopes and things like that. So they're not medical people; they're physicists and weird particle physics stuff, but you know, it affects our ability to use nuclear medicine. And you know, in my past, I've reviewed accelerator systems for medical isotopes at nuclear reactors and such like. And so there's a breadth that you get, and a lot of patients, you know, with their backgrounds would really like to be helping the health system. And it's that sort of capability that can also be out there when you're looking from a research point of view of how do I enhance my research by just reaching out to patients as volunteers.
No, amazing. It's super exciting. I know for everyone, I mean, that's why we're all here today, because it is very exciting. And Nick, Catherine,
I could jump
Ashley,
in.
yeah.
If you want. Yeah, I think that rural health research has a unique need for sure. Like, it's a little different than other centers, and also building that foundation is very exciting. It, you know, just, I don't know, it's nice being part of it, and just to build that foundation to make sure it's strong, and just to get the patient needs heard, to kind of integrate it into that foundation, like I said, because it's probably going to be unique. And like Dr. Jaworsky mentioned too, it's difficult to get it done, but I think we can definitely show that we got this and we can move forward with it. So it's very exciting. It's exciting to be part of it. And I appreciate the opportunity. Absolutely. So thank you.
Oh, thank you.
I can speak as well. Mostly just what I've been thinking about is like coming up to being a new grad and what these clinical trials will look like as a new grad nurse going forward, like where we'll be involved and stuff like that. I'm just really excited to see how it unfolds, I think, in our hospital here.
Perfect. Well, we're excited that you were all able to join us today. Catherine, maybe I'll give you the last word if you want to jump in.
Sorry. Yeah, being raised in the Fraser Valley, I saw like the opportunities that healthcare and research has down on the coast. And then when I moved up here to Cranbrook for school, I really fell in love with the mountains and the rural communities. So really excited to see how research grows in our community.
Amazing. Well, thank you so much for all of you for being with us today and for sharing. So thank you to Denise, Jen, Nick, Ashley, Catherine, and Paul. And I guess I lied when I said I'd have time for other people to ask questions, because we don't. But I know that they'd be happy for you to reach out to them. So we'll be sure to continue sharing.